Hello! Welcome to the Benzodiazepines and Older Individuals microlecture. My name is Rebecca Bringelson. I'm a board-certified geriatric pharmacist and School of Pharmacy faculty member at North Dakota State University in the School of Pharmacy. At the completion of this microlecture, the participant will be able to 1. Identify selected recommendations from the 2023 AGS Beers criteria surrounding the use of benzodiazepines. 2. Describe the evidence-based clinical practice guideline and deprescribing algorithm included in the citation on the screen and in the reference list by Potty and colleagues titled Deprescribing Benzodiazepine Receptor Agonists, Evidence-Based Clinical Practice Guideline. In 2023, the American Geriatric Society, AGS, updated the AGS Beers criteria and published the update as a special article in the Journal of the American Geriatric Society. The citation for this article is on the screen before you. This article is an evidence-based guide for practicing clinicians to identify potentially inappropriate medication, PIM use in patients 65 years and older in ambulatory, acute, and institutional settings. It is noted that these guidelines do not apply to settings where patients are in hospice or receiving end-of-life care. Let's see specifically what the AGS Beers criteria has to say about benzodiazepine receptor agonists and non-benzodiazepine receptor agonist hypnotics, Z-drugs. If you recall, the 2023 AGS Beers criteria are organized into 5 tables with the following titles. 1. Medications considered as potentially inappropriate, Table 2. 2. Medications potentially inappropriate in patients with certain diseases or syndromes, Table 3. 3. Medications to be used with caution, Table 4. 4. Potentially inappropriate drug-drug interactions, Table 5. 5. Medications whose dosages should be adjusted based on renal function, Table 6. The quality of evidence ranges from low to high, and the strength of recommendation ranges from weak to strong. Benzodiazepine receptor agonists and non-benzodiazepine receptor agonist hypnotics, Z-drugs, appear on multiple tables throughout the Beers criteria. Tables 2, 3, and 5 have criteria to help to address benzodiazepine receptor agonists and non-benzodiazepine receptor agonist hypnotics, Z-drugs, to help minimize adverse effects from the use of these medications. This will be the focus of today's presentation. Participants are encouraged to review the 2023 AGS Beers criteria to assure that they understand the recommendations surrounding benzodiazepine receptor agonists and non-benzodiazepine receptor agonist hypnotics, Z-drugs, noting that the medications discussed may have additional rationale and recommendations surrounding the recommendation to avoid use that may not be covered in this presentation. First, Table 2 identifies, quote, potentially inappropriate medication use in older adults, end quote. Benzodiazepines and non-benzodiazepine receptor agonist hypnotics, otherwise known as Z-drugs, as listed in the table. The rationale for the recommendation for both groups of medications is similar. The information listed under benzodiazepines is quite extensive, outlining potential risks related to abuse, misuse, addiction, and physical dependence in addition to other risks. Quote, in general, all benzodiazepines increase the risk of cognitive impairment, delirium, falls, fractures, and motor vehicle crashes in older adults, end quote. Additionally, the rationale for benzodiazepines does include some indications where use of these medications may be appropriate, including, quote, seizure disorders, rapid eye movement, sleep behavior disorder, benzodiazepine withdrawal, ethanol withdrawal, severe generalized anxiety disorder, and paraprocedural anesthesia, end quote. This is a strong recommendation with a moderate quality of evidence. The information listed under non-benzodiazepine receptor agonist hypnotics, otherwise known as Z-drugs, has the added notation that use of these medications results in very little improvement in time to sleep or length of sleep. This is also a strong recommendation with a moderate quality of evidence. Next, Table 3 identifies, quote, potentially inappropriate medication use in older adults due to drug-drug or drug syndrome interactions that may exacerbate the disease or syndrome, end quote. We see both benzodiazepines and non-benzodiazepine receptor agonist hypnotics, otherwise known as Z-drugs, as listed in the table as medications, to avoid along with other medications in 3 different sections under the central nervous system, delirium, dementia, or cognitive impairment, and history of falls and fractures. The rationale for each is provided as well. For delirium, the rationale provided is, quote, avoid in older adults with or at high risk of delirium because of the potential of inducing or worsening delirium, end quote. For dementia or cognitive impairment, the rationale provided is, quote, avoid because of adverse CNS effects, end quote. For history of falls and fractures, the rationale is as follows, quote, may cause ataxia, impaired psychomotor function, syncope, or additional falls, end quote. There is some additional medication class-specific information provided for guidance in both the rationale and recommendations. The recommendations note that with benzodiazepines, short-acting benzodiazepines are not safer than long-acting benzodiazepines. This is a strong recommendation with a high quality of evidence. Finally, the recommendation from Table 5 titled, quote, potentially clinically important drug-drug interactions that should be avoided in older adults, end quote. Here we see two different rows with recommendations. The first recommendation is related to concurrent benzodiazepine use with opioids. The rationale for avoiding using these medications together is as follows, quote, increased risk of overdose and adverse events, end quote. This is a strong recommendation with a moderate quality of evidence. The second recommendation recognizes benzodiazepines and non-benzodiazepine receptor agonist hypnotics, otherwise known as Z drugs. The recommendation here is to avoid using greater than or equal to 3 CNS active medications, and really to use the smallest number of CNS active medications when possible to avoid increased risk of falls and fractures. This is a strong recommendation with a high quality of evidence. Let's look to the literature to review the evidence-based clinical practice guideline by Potty and colleagues in the Canadian Family Physician, published in 2018, titled Deprescribing Benzodiazepine Receptor Agonists, Evidence-Based Clinical Practice Guideline. The citation is found on the screen here, as well as at the end of the presentation in the reference section. The final recommendations and deprescribing algorithm developed by this team includes both benzodiazepines and non-benzodiazepine receptor agonist hypnotics, otherwise known as Z drugs. This Canadian-developed evidence-based clinical practice guideline is also available online at deprescribing.org, where additional resources, including patient education materials, are available. The deprescribing algorithm and notes for benzodiazepines are also provided at the online link found on this slide. First, let's discuss the methods used to develop these clinical practice guidelines. An interdisciplinary team of 8 developed these guidelines that including, quote, 1 family physician, 2 psychiatrists, 1 clinical psychologist, 1 clinical pharmacologist, 2 clinical pharmacists, and 1 geriatrician, end quote. They also had 1 additional individual whose expertise was methodologies relating to grade recommendations in guideline development. The grade guideline development system was used with the following question, quote, what are the effects, harms, and benefits of deprescribing benzodiazepine receptor agonists compared with continued use in adults with insomnia, end quote. They also looked at deprescribing strategies and created a definition that included different strategies used to deprescribe benzodiazepine receptor agonists. Then, a scoping review was conducted, first followed by a systematic review that examined the different approaches in the literature to deprescribing utilizing the definitions previously determined by the work group. Quote, primary outcomes included sleep quality, effect on cognition, improvement or worsening, adverse drug withdrawal events, cessation rate, proportion of patients who completely stop benzodiazepine receptor agonists, and harms, daytime sedation, balance, motor vehicle accidents, falls, mortality, dependence. Secondary outcomes included benzodiazepine receptor agonist pill burden, average benzodiazepine receptor agonist dose, and patient satisfaction. End quote. Clinical recommendations were formulated using grade evidence tables. The GDT team members discussed clinical recommendations and voted electronically. They used 80% as the percentage of votes needed for consensus, however, all group members agreed with the final recommendation. While the focus of this presentation is on older individuals, quote, the recommendations apply to adults aged 18 and older, including elderly adults living in the community or in long-term care facilities who take benzodiazepine receptor agonists for the purpose of treating primary insomnia or comorbid insomnia where all potential underlying comorbidities are effectively managed, end quote. The final recommendation for older individuals is, quote, for elderly adults, greater than or equal to 65 years, who use benzodiazepine receptor agonists. We recommend the following. Taper the benzodiazepine receptor agonist dose slowly. Strong recommendation, low quality evidence, end quote. This recommendation does not conflict with the current clinical practice guidelines for primary insomnia. In the primary insomnia guidelines, along with the 2023 AGS-Beers criteria, it is recommended to avoid the use of benzodiazepines in individuals over age 65 years. This brings us to our first clinical consideration. Insomnia can be caused by many other conditions. Always consider the cause of the insomnia when considering deprescribing. There may be underlying conditions and/or comorbidities that need to be adequately treated before deprescribing can be successful. Patient attitude toward and overall engagement in deprescribing is very important. The decision to begin any medication requires shared decision-making, and the decision to deprescribe a medication is no different. The literature has shown that conversations are critical. At the bottom of this slide, and in the reference section, you'll see the citation for an article recently published in the Journal of the American Geriatric Society titled Evaluation of a Benzodiazepine Deprescribing Quality Improvement Initiative for Older Adults in Primary Care, along with a citation for a commentary on the same article in Pharmacy Times discussing the role of conversation in benzodiazepine deprescribing. The clinical practice guidelines we're reviewing today outline several topics that should be included in patient conversations. First, it is important for patients to understand the risk of ongoing benzodiazepine use and how tapering off these medications could benefit their health over time. It's also important to discuss how they might feel if they begin to taper their medication, not only in relation to diminishing therapeutic effects, but also withdrawal symptoms. Withdrawal symptoms from benzodiazepines during a taper are usually mild and transient with dose decreases and can include irritability, sweating, anxiety, and GI symptoms. There are recommendations in the clinical guidelines for how to manage withdrawal symptoms that are more persistent and severe. Quote, if withdrawal symptoms occur at a severity and frequency that is too bothersome for a patient to consider maintaining the current benzodiazepine receptor agonist dose for 1 to 2 weeks before attempting the next dose reduction, then continue to taper at a slower rate, end quote. Finally, the literature review for the clinical practice guidelines indicates that the patient having a specific tapering plan and patient education along with routine monitoring seems to be most effective. The group working on these clinical practice guidelines reviewed tapering strategies used in clinical trials and used these to inform the guidelines. The tapering strategies used for deprescribing used in 10 clinical trials are described in Table 2. However, there were no clinical trials that directly compared one tapering strategy to another. In general, they found, quote, very gradual dose reductions to lowest dose, for example, 25% reduction every 2 weeks, and a slower taper of 12.5% every 2 weeks near the end of stopping, followed by periodic drug-free days, were used successfully in clinical trials, end quote. Further, quote, when deciding on tapering doses and rates, consider using a slower rate with those more likely to have a higher history of relapse, for example, long-term use or history of psychological distress. Some clinicians would recommend tapering over several months. Such patients require closer monitoring and support, end quote. This brings us to monitoring. It is recommended that patients are monitored every 1 to 2 weeks during benzodiazepine tapering. If you have a pharmacist working with you in your practice, this would be a great opportunity for collaboration. We're looking to see the negative effects of benzodiazepine use improve. Examples include decreased daytime sedation and increased alertness. Withdrawal symptoms have been previously discussed. Finally, we're also monitoring for changes in sleep. This includes amount of sleep and sleep quality. As a non-pharmacological approach, behavior management and cognitive behavioral therapy, CBT, have also been shown to help improve insomnia. The next 2 slides show images of Figure 1, the benzodiazepine and Z drug deprescribing algorithm created as part of the clinical practice guidelines. As mentioned previously, a link to this algorithm as well as patient education materials can be accessed online at deprescribing.org. I'll highlight just a few areas on each side of the 2-paged algorithm. The first key decision point in the algorithm is determining why the patient is utilizing the medication. Then, if the patient is using the medication for primary insomnia or quote insomnia, where underlying comorbidities are managed end quote, then a patient conversation and shared decision making may result in the recommendation to deprescribe the medication. There is guidance on tapering and monitoring. On the back of the flowchart, there is additional information to engage patients and caregivers, taper doses, provide behavioral management recommendations, and guidance on when to recommend cognitive behavioral therapy. This concludes the benzodiazepine receptor agonist microlecture. This slide provides the references for the presentation. Thank you.